Good morning, everyone. I hope everyone had a wonderful first day at the meeting and had a restful night. I hope it was restful as well as fun. We have an exciting day ahead and something that's very, very special to start the day. This morning's session is called Battle of the Giants. We have some true icons in heart valve disease and in cardiovascular science that will be presenting to us this morning. The first is regarding the COAP trial, which everybody knows has been an exciting addition to the recent literature, both pros and cons. And the discussants or the debaters this morning will be Professor Blasé Carabello and Jean-François Obadia. So what I propose is that we start with 10 minutes from each, and then we allow 10-minute rebuttal at the end. Let's keep it fresh and lively and non-personal, so that we stick to the issues and not the people. So with that, I would like to introduce my esteemed co-moderator, Ourania Preventza. Do you want to say your name properly? Sorry.
Yeah, it's okay. Ourania Preventza.
Okay. So, and she's going to provide some excellent context for us this morning. So with that, I'd like to invite Blaise to come to the stage.
Well, thank you. I'm not sure how much of a debate this is going to be. I suspect Jean-François and I pretty much agree on the findings, but it'll be interesting to go through. So obviously everybody knows that COAP was a randomized trial comparing the mitral clip in patients with secondary MR against optimal medical management. Let's see. So their primary endpoint was a reduction in recurrent hospitalizations for heart failure, with secondary endpoints composite of 30-day all-cause mortality, stroke, and MI, or surgery for device-related complications, 1 year all-cause mortality, and then a change in MR severity, 6-minute walk, quality of life, remodeling, a New York Heart Association class. And in 2017, I was asked to give a talk about what I predicted the results would be. And I predicted then that they would make their primary endpoint of a reduction in hospitalizations for heart failure. I said that their secondary endpoints, we knew the clip would reduce severity. We already knew that it led to reverse remodeling of the left ventricle, and I thought that New York Heart Association classification would improve. And the reason I said that was based a lot on these acute data from Purley et al. That looked at the effects of placing the clip on acute hemodynamics. And the clip reduced filling pressures and increased cardiac output. So guess what? I mean, those are the things we try to do with medical therapy. These were patients already treated with medical therapy. If the clip provided those kinds of changes in hemodynamics, I thought that it would reduce hospitalizations due to heart failure. I wasn't sure about quality of life and 6-minute walk, and the reason I questioned that were these data from the Cleveland Clinic that looked at patients with ischemic MR, CABG alone versus CABG with a mitral valve annuloplasty, and 2 years out there was really no difference in New York Heart Association late classes, and their conclusion had been that although CABG and mitral valve annuloplasty reduces postoperative MR and improves early symptoms compared with CABG alone, it does not improve long-term functional status or survival in patients with severe functional ischemic MR, Tommy Mihalovich and colleagues in 2007. And I said I would be surprised if they made their composite endpoint of 30-day all-cause mortality, et cetera, and 1 year all-cause mortality, because nobody had ever demonstrated that it worked. So these were from Steve Bowling's group, one of the first people to suggest that you could actually treat secondary MR, and there was no difference between restrictive annuloplasty and medical therapy. In this small randomized trial, which was not powered for a mortality difference by Fatucci and colleagues, there wasn't even a signal that surgical treatment of MR would reduce mortality. And then when you look at the CTS randomized trial, which the purpose was to compare mitral valve replacement with repair. But the reason I'm showing the slide is that 2 years out, the mortality was 20%, 10% per year, which was pretty much what it's always been, in that 10 to 15% range. So my reason when I said that I didn't think that the clip would alter mortality was nobody had ever demonstrated that mitral valve repair, at least surgically, would alter mortality. And then there was this meta-analysis of almost 3,000 patients that also showed no benefit in survival and no improvement even in symptoms with mitral valve repair in secondary MR. I said that's why we call it secondary MR. It's secondary to another cause, disease of the ventricle, and not treating that disease primarily, you wouldn't expect a change in mortality. And then the mitral FLR trial comes out, and it sort of proved everything I said. There wasn't any difference. Jean-François will talk about this in a minute. But okay, and then of course comes COAPT, which was striking in the differences, where there was this huge difference in rehospitalization for heart failure, needed to treat only 1 in 3 patients, and an improvement for the first time, any device, in a randomized trial of mortality, needed to treat just 6 patients. And so, obviously, and we'll hear from him in a minute, why the differences? Well, they were different patients. Age was about the same, but the effective regurgitant orifice was much larger in COAPT. There was more MR, and the ventricles were smaller. Ejection fraction, which is a horrible tool, shouldn't be used in MR to begin with, but it is. What can I say? And so these were patients in COAPT with more severe MR, smaller ventricles, and there was a very aggressive stance taken by the screening group to make sure that patients were really treated to the absolute maximum with medical therapy. I had patients rejected because we had not treated them aggressively enough, because guideline-directed medical therapy works going back 32 years, to these data from Lynn Warner Stevenson, looking at what really aggressive, and in this case a Swan-Ganz-directed medical therapy, reduced end diastolic volume and practically got rid of mitral regurgitation. So that if you really take aggressive medical therapy and after you're done, you still have severe MR, then I interpreted this to what I call tertiary MR. That is, there's so much secondary MR left that it no longer is a bystander. It is no longer a product of ventricular dysfunction, but rather is actually causing additional ventricular dysfunction by itself. And that tertiary MR then is a target for additional therapy, i.e. the mitral clip. Paul Grayburn interpreted those data slightly differently. And his idea is that it was a bad fit. The ventricles, for whatever reason, in COAPT didn't enlarge enough to accommodate the severe MR that was left over, leading, of course, to increased filling pressures and reduced cardiac output. Not sure that he and I actually talked about this at length. I think both concepts are kind of interesting. And then, so the question now is this the new gold standard for the treatment of secondary MR? And what would you do with this patient, a 60-year-old diabetic man with 3-vessel coronary disease and severe secondary MR? The Freedom trial says he should go to surgery for his coronary bypass, for his revascularization of his coronaries. But COAPT might say that, yeah, but should he get a surgical repair at the time of his coronary bypass surgery, or should we put a clip in first and then send him to surgery? I obviously have no idea the answer to my own question, but it's an interesting one to think about. Anyway, my views on COAPT. Thank you very much for your attention.
Thank you. Thank you, Blaise. Now I'd like to invite Professor Obadia. Yeah, please.
Thank you for your invitation. Okay, excuse me. Okay, so I have to discuss the respective weight of those two studies published in the New England Journal of Medicine last year. And these are my conflicts. And two different studies, and you see two different results. I remember when I presented those results in Munich, it was a sad day. Everybody was crying in the assembly, and Abbott was close to suicide. While 1 month later, it was exactly an opposite ambience. With when Greg Stone presented his study, every other slide, people applauded in the assembly. So two different aspects, two different results, and we have to explain that. And it has already been said by Blaise, and thank you for your comments. And I agree with you that the difference in the recruitment of the patient probably explain those different results. Actually, in MITRA-FR, we have less severe MR and more severe left ventricle, and this is probably the main explanation. In MITRA-FR, we probably recruited too late the patient, while in COAPT, the selection was more accurate. We also have to remind us that MITRA-FR is an academic study supported by the French Ministry of Health. You see that the publication of the protocol have been done in 2015, 3 years before the publication of the result, with absolutely no modification in the protocol. While for COAPT, this was completely different. Of course, this study was followed by the FDA, but they have changed the protocol all along the enrollment period, and at the end, they had to double the number of patients who had to be enrolled in the study. So the philosophy of those two studies were different. And if we compare the quality of the expertise of the centers who were participating to the enrollment, you see that in COAPT, they had 3 patients in the roll-in period, meaning they had to do at least 3 clips before there was selection, the site was selected to enroll patients, while in MITRA-FR we had to enroll 5 patients. The device success was very similar in the 2 studies, and also the quality of the reduction. So the expertise of the 2 teams on both sides of the Atlantic was very similar. But if you look at the flowchart from MITRA-FR, you see that we had to exclude 32% of the patient, and in COAPT, they excluded 61% of the patient, mainly for the reason reported by Blaise just before me, when he said when they had a patient that they wanted to take care to the quality of the medical treatment, and they refused to enroll patients if the medical treatment was not absolutely accurate. While in MITRA-FR, we didn't centralize the selection of the patient, and every center was responsible for the decision if the medical treatment was optimized. So maybe in MITRA-FR we were less severe on the selection of the patient. But if you look, this is one of the main critiques we can address against COAPT, because you see the bigger centers, which is Cedars-Sinai, included 46 patients during 5 years, meaning 8 clips per year. So the biggest center in US include less than 1 clip per month. So the selection is very, very severe. So that today, I don't think that the patient who receive a clip worldwide are not so well selected. And if you look at the complication in both studies, we have the similar rate of complication, and we confirm in MITRA-FR and in COAPT the technique is very safe, the technique is efficient. You see the procedural success. These are the 3 randomized studies, Everest 2, MITRA-FR, COAPT. Everest had, it was the first one, 77%, but today the success rate after a clip is very high, over 90% in the 2 prospective randomized studies, but also in the biggest registry in Northern Europe. And if you look here, this is the baseline value, grade 4 and grade 3, and are discharged, so the clip is efficient, even if there is still recurrent MR after 1 year. The medical treatment was also efficient, but of course the clip was much better than the medical treatment. But no impact in MITRA-FR, no impact on our primary endpoint, all-cause death, and the first unplanned rehospitalization for heart failure. Moreover, if you look at the subgroup analysis in MITRA-FR, we only have one trend when the mitral regurgitation is severe, and this is probably a start to accommodate the result of the 2 studies, while if you look at the subgroup analysis of COAPT, every subgroup is positive. So the results are really different, and the explanation has already been said, probably the severity of the MRs and also the dilatation of the ventricle is the explanation. So probably this should be the conclusion, the easiest conclusion. Every study is important. We didn't look the same way to the secondary MRs, so the results are different. But now, since it is a debate, and I have also to address some questionable aspect of the result of COAPT. And for instance, it has been repeated that here, before the enrollment, the patients were very, very highly selected. The medical treatment was perfect, and the patient was supposed to be stable. How can you explain that just after the randomization, all of a sudden, the patients start to be hospitalized? And if you look here, you see that after 1 week, they already are more rehospitalized in the control group. Meaning, at this time, the patient have not yet received the clip, and there is already a difference. This is the weakness of an open study, and probably the fact that the people knew that who groups they belong to influence the decision to rehospitalize or not. So this is probably a weak endpoint, and this was a primary endpoint of COAPT. But this is the most important slide in COAPT. It modifies the mortality, and we have to accept it. And this is a fantastic result, and we have to congratulate the team of COAPT to have been able to select accurately the patient, because this is the only paper in the literature who shows that treating the secondary MR has an impact on the follow-up of the patient. Maybe we could explain at least partially this difference, because if you look at the medical treatment in COAPT, there is a statistically significant difference at baseline. So the control group in COAPT was not as well treated as the MitraClip group. And it was true at baseline, it was true during the follow-up, but you see the difference is not very high. But this may explain, at least partially, the difference in mortality, even if it cannot explain everything. But we have the feeling that the medical treatment, in COAPT, they didn't give the best chance to the medical treatment to be efficient. Here you see on the same slide the mortality of the control group of COAPT and MITRA-FR. So you see, we used to say that the selection was different, but when you put on the same slide, it's not evident. We have the feeling that it was more or less the same patient, because the control group of COAPT is very similar to the follow-up of the MITRA-FR patients. And this is also very impressive, because this is the only paper in the literature where you have the feeling that treating a secondary MR is forever. In any paper in the literature, the weakness of treating secondary MR is a recurrence of mitral FR. This is true for surgery and very, very important. In the Estes trial, it represents 32% after 1 year. And here, absolutely no. And moreover, if you look in COAPT, we still have patients with grade 1 or grade 2. We know that the clip is not perfect. And we also know by this paper, if you have a grade 2 regurgitation, we should have an impact on the mortality. Why this does not appear inside the COAPT result? There is some question in COAPT. And these are two slides which have been presented during the recent American College of Cardiology. And for instance, this is questionable. I don't understand those slides. For instance, you see the end diastolic and systolic diameter. This means 60 milliliters of ejection altogether. That is very easy, just simple mathematics. So, and here on the other slide, the regurgitation volume is 59. So this means that the stroke volume should be 1 milliliter. This doesn't make sense. There is something wrong somewhere. So you see that it's not easy. Of course, this is this paper and proposed by Graben, the ejection fraction. You have to interpret the regurgitation surface according to the end diastolic volume. We also have to propose to add the ejection fraction in a 3D representation, and maybe this is an elegant way, but we probably need a new definition for secondary MR, a more integrative approach of all the parameters of the ventricle. And this is the conclusion. Safety and efficacy, we agree, they are very good with the clip. It's a safe technique. It's efficient on controlling the MR, not perfect, but efficient. But, and probably mitral FR included too late and too large, not enough selection. Probably COAPT, on the opposite, had a very narrow and very accurate selection. And today, the mitral clip has to be, it's a good and important message for our community. It's important to treat severe regurgitation when it is not too late. And this is work for the heart team, and the clip is not a solution for any patient. I think a mitral valve team should offer our patient from sternotomy to percutaneous replacement or clip or whatever, or mini-invasive surgery. And this is a discussion for the heart team, and this is probably the most important message. Thank you for attention.
That was lovely presentations, both of you. Have a seat and we can talk. Ourania, do you want to take us through a little talk? We have about 5 minutes just to stay on time.
So we heard both of you actually saying about the COAPT. So I would like to ask you, so I'm a 75-year-old and I have moderate to severe MR and I have 2-vessel coronary artery disease. My LAD is 85% and my RCA is 80%. So what do you guys recommend? And I have a very severe COPD. My FEV1 is 25%. So what do you guys are going to do? I'm in your office, and you really have to tell me something.
Well, so I don't think any surgeon is going to want to operate on a patient with an FEV1 of 25%. And I don't know that you would get much improvement. And also, it'd be very hard to know whether your dyspnea is due to the mitral regurgitation or the COPD, which I suspect the COPD is dominant. I think that patient probably gets 2 stents, and if the MR is only moderate, I'd leave it alone. I wouldn't touch it. I would treat you with medical therapy and 2 stents.
Okay, 6 months down the line, I still have shortness of breath, and I'm really symptomatic.
But you only have an FEV1 of 25%, and I can't make your lungs any better.
What do you think?
Well, I think you also have to do a stress echo and to try to see if there is a contractile reserve. There was, with mitral FR and COAPT, some parameters have been taken into account, but we don't have to forget what we have learned after 30 years of surgery. And we have published with Robert Dion, with David Adams, with Steve Bowling, some parameters who are highly predictive of the success rate after a mitral valve repair. repair. Of course, it is a surgical valve repair, but we have some data. We know the end diastolic diameter. We know the angle between the posterior leaflet and the annulus. We know the tenting area. So there are many details we have to be taken into account before you take the decision. And altogether, this has to be discussed in a heart team, I think. And this is the best way to give every patient the best chance. But I agree. For the first step is to give the medical treatment the chance to be positive. And I would have done, as you said, treat medical treatment first, and then you can discuss after.
Do we over or underuse the MitraClip, in your view? Both?
Yeah. We use a few clip in my institution.
I suspect that maybe 1 in 10 patients with secondary MR is a clip candidate. First, as you say, we can't wait. If we've waited too late, we probably are not going to get, and if the ventricle is huge. And this 130 end diastolic volume index has actually come up in other studies as maybe a cut point where the ventricle is not going to recover. And then after you treat them, I believe that these patients should have a BUN of 30 and a blood pressure of 90. That you've really beat the hell out of them with medical therapy. And then if they still have severe MR...
People say surgeons are mean.
and then maybe, but I think unfortunately many people will overstate the coapt case and want to use a clip on everybody. And as you say, I think it's a very rare patient that's the two studies, in my view, work beautifully together to tell us whom we should be treating. And there are not that many out there that qualify.
Jean-François?
No, I agree.
Anything else? Finish? Great. Well, thank you very much, both of you. A big round of applause for our debaters. And let's invite both speakers up now, Professor Magdi Yacoub and Professor Patrick Serruys. Let's come up to the stage, and we'll start with Prof. Yacoub. Is Serruys here? Is Professor Serruys here? Great. Why don't you come up? Join us at the table. Thank you. Good morning, Prof. All set?
Hi. Thank you, Najma. My great colleague here helped me to come up the stair because I had an operation on my back only 2 weeks ago. I still suffer. That does not prevent me from debating very strongly with my colleague there. Now I have the highest respect and admiration for my colleague. However, I'm extremely disappointed, almost alarmed, that he chose to ignore the fact that there is a difference between life and death. How can you compare a living tissue? I tried to explain that yesterday, that a tissue-engineered heart valve is a living tissue. But my colleague here, my respected, highly esteemed colleague, chose to ignore the difference between life and death. I tried yesterday, almost desperately, to show that life, whether it's in a tissue, in a cell, in the extracellular matrix, actually imparts almost magical properties to the valve. To any of us, I tried to support that by both theoretical, experimental, and clinical data. But he chose to ignore all that and say that a piece of tissue from wherever you get it from, the source which is dead and fixed, is just as good as a living tissue. Now I will reiterate very quickly the source of my alarm. about this notion that living equals dead. A living valve, as I showed yesterday, actually is capable of adapting, of growing, of performing incredibly sophisticated functions, which actually translate into clinically relevant endpoints. Like what? Like quality of life, and we have ample evidence that the only living tissue valve is the Ross operation, and the quality of life is superior in several studies. Hemodynamics, you can show you beautiful pictures how it opens and shuts. Distribution of blood to different organs, capacity to adapt during physiologic and pathological conditions, and importantly, in the longer term, is capable of growing, and durability. Do you care about durability? A living valve, as Don Ross has shown, and we followed him, and now almost 50 years later, Donald has proved to be right, that we have follow-up of 42, 44 years. Najma here has looked at the histology of these valves. It's incredible. So how can you say a living tissue-engineered heart valve is not superior to a fixed, whatever you do with a glutaraldehyde, or whatever you do, it's just not equivalent to a tissue valve, a tissue-engineered heart valve. Now, giving time over it, as I said yesterday, the last 20 years has shown a lot of progress. Not enough, because we have just entering the clinical arena carefully, as we should. But the next 20 years, I hope, will be ample for accelerating this progress, because, as I said yesterday, we have many tools to accelerate the clinical, to getting it to the clinical arena. I remain very disappointed about the fact that my highly esteemed colleague does not accept what is so obvious. I don't know why. Thank you.
Well, now we're going to find out why. So, Prof, please sit here. Okay, you can sit. Yeah.
I can sit here?
So let's.
Yes, please.
Okay.
Now we'll find out why. So, Professor Serruys.
Good morning.
Morning.
So, the title of this debate was Tissue-Engineered Valve Will Dominate in 2031. Now, I was amazed that yesterday it was expanded to 2039, so the timeline has been expanded, as I said yesterday. I had a previous debate with Sir Magdi Yacoub in 2007, that's 12 years ago, and at that time the motto of the title of the debate was the aortic valve will be replaced by catheter even for the standard patient with aortic valve disease in the near future. I was pro, he was con. We were in 2007, and I'm a poor debater, and he's a great scientist. So I have my share of debate with Celia Oakley in 1982. In this house, a patient with MI will be treated with morphine, oxygen, and gentle care of a nurse. I was in favor of thrombolysis. I lost the debate. With Raphael Balcon in London in 1982, balloon angioplasty is doomed to disappear. I was con. I lost the debate. PCR will never be applicable to patients with multivessel disease, 1987, ACC against Bruce Little. I was gone, I lost, etc. Use of stent as a bailout with David Holmes, you always lose. Provisional stenting is the way to go. Again, with David Holmes, I lost. But that one, the aortic valve will be replaced by a catheter. So I can already draw a conclusion. If you debate with me, you will always win, Magdi. But historically, you will lose. So the aortic valve will be replaced by a catheter even for the standard patient with aortic valve in 2007. In that debate, I felt like this small rabbit, you know. I had done at that time 62 percutaneous valve, well, 8.6% of the worldwide cases at that time in 2007, but Sir Magdi had thousands of valves under the belt. But this year, the interventional cardiologist Marta Leon said in the New England, TAVR through 1 year should be considered the preferred therapy in low surgical risk aortic stenosis patient. And the surgeon, Michael Reardon, in the New England said TAVR may be a preferred strategy to surgery in patients with severe aortic stenosis at low risk of surgical mortality. Back then in 2007, I felt like this small rabbit, but nowadays I feel much better after 500 million percutaneous valve. Okay, now let's be serious. The wolf is right. The wolf is right if you look at the paper of Bourguignon, the valve deterioration, structural valve deterioration in the Carpentier-Edwards pericardial perimount, it's clear. I mean, if you operate and put a bioprosthesis, an individual which is less than 50 years old, what you can expect 20 years later is a severe structural valve deterioration. So is them right? An old TAVR system will certainly demonstrate at some point some degree of valve deterioration, degeneration, let's say 10 years. So far it sounds good, but wait and see. But the wolf, Sir Magdi, in the meantime, has worked intensively. Look at that. Novel approach to cardiac valve repair, 2004. Will heart valve tissue engineer change the world? Anneke was involved, 2005. The private life of tissue valve, it looks like the private Ryan, but okay. Hydrogel scaffold for tissue engineering, progress and challenge. The living aortic valve from molecule to function. And finally, a few years ago, in search of living valve substitute. Now, again, I feel like a small rabbit in this debate, but I'm fortunate to have in the Netherlands a place with remarkable scientists working on endogenous tissue restoration, and I've been working with them since 2004. The idea is to have a matrix of biodegradable material. The red cell will go into it, as well as the macrophage, and then there will be some cell-mediated digestion of the matrix. The fibroblasts will come. They will create a network, a matrix of collagen and elastin. And, of course, the APC will cover the device. So endogenous tissue restoration is a technology combining three scientific disciplines. One is the supramolecular chemistry, and I admire this man, Jean-Marie Len, Nobel Prize in Mind in 1987, which is able to provide us with a library of molecules which are strong and with different speed of bioresorption. So you can create a tunable material for a platform. The second point is electrospinning. You pulverize the polymer, you have an electrical field to let it spin, you end up with this kind of matrix, and with this matrix you can do a lot of things, valve and pulmonary tube, and you have seen the video showing the process. So we agree on one thing, is that the animal-derived glyceraldehyde fixed foreign material access is an issue, inconsistent material performance is an issue, there are manufacturing difficulties, there are chronic inflammatory response, leaflet thickening, thrombose, structural valve degeneration, systemic anticoagulation, and resurgery of valve-in-valve. The endogenous tissue restoration is on the shelf. It's a dry storage, reduced profile, scalable and predictable manufacturing, and improved biocompatibility resulting in less leaflet thickening, thrombose, reduced need for anticoagulation, and improved durability. Now, this is an example of pulmonary valve conduit over time. Here is the device. Let's look at the free margin after 2 months, 6 months, 12 months, and 24 months. You could see that Mother Nature has rebuilt the things and has encapsulated the template, the matrix template. If you look at the site of the coaptation, which is a very important site, you see the same phenomenon after 12 months. And if you look at the basis, here is after 12 months, the conduit is covered. You see some kind of excess of neointimal thickening at the basis. The hinge is, of course, the weak point, so you're not surprised to see partial breakdown of the leaflet with inflammation. You see the extension of the neointima up to 2/3 of the valve, and then later on you see the ingrow and the complete coverage. So there have been work done. 5 kids have received a Fontan, and we follow them with MRI velocity of their Fontan. There's been 18 pulmonary valve conduit, 12 in Europe and 6 in the United States, and we follow them with multi-slide CT scan of their conduit. There have been surgical implantation in mitral, and I will focus for a few minutes on the aortic valve. So what we did in these 53 animals, we followed them acutely and chronically with the classical technique, and as you could see, the results are very good, at least acutely. As you could see, the post-implantation, peak gradient 7.4, mean 4, effective orifice area 2 centimeters square. And the concept is that you use to that a clipping system and a self-expanding system. You can see the different phase and the final result. Why the clipping system? Because we work in sheep. We have no way to anchor a balloon expandable technique. Now, we face a complex biological equation. I agree with Magdi, it is not simple. You have this complex biorestorative process. We had to work on the sheep, which has a fragile aorta. You cannot use a balloon expandable anchoring system. It has a tendency to calcify, and there is a difference in sinotubular height. And the metallic support, as I said, is self-expanding and clipping. Already in the sense, the sinotubular structure play a role, and maybe after 2031 we will resolve this problem. One of the problems that we face is that we saw the inward motion of the post supporting the leaflet, what we call the pinwheeling effect, which is certainly something that I would like to eliminate by all means. Now, Sir Magdi has published in the Qatar Foundation Academic Journal. I don't read that journal every day, but I found very, very impressive. What he did is taking cell from the human body, then you have to go to expansion of the cell, then you have to put the cell in very complex technology, which is the hydrogel. We can speak hours on the difficulty to work on hydrogel. And then again, you have to place the model in culture, and then you have to do some kind of direct injection or go back to surgery. I think that equation will not be resolved tomorrow, but maybe after 2031. Cell seeding or seeding with growth factor face enormous regulatory challenges. I can tell you about that. Pharmaceutical product, high cost, and difficult to get funded. I get in this business quite early. I mean, in 2003, I published in JACC my first attempt to use autologous skeletal myoblast and inject in the myocardium, guided by electromapping, and I was targeting the border zone. Now, I can tell you I had to puncture the thigh of the patient the day before to stimulate the myoblast, then make a biopsy, go to Schiphol, ship the whole things to Johns Hopkins, have cell expansion for 15 days, go back to Schiphol and inject in the patient. And it didn't work. So let's go back to the sheep for a moment. Acute and chronic assessment of valve performance by quantitative autography. That's something we have developed quite recently. It's basically time density in the aorta versus the outflow tract, which is just a ratio which expresses the result from 1% to 100%. You can see here the video densitometry of the outflow tract. That's very nice. A technique to measure the aortic regurgitation. And we were very happy in some animal. Look at the acute phase, 2% of regurgitation. 1 year later, 1%. Amazing. But we had also animal where you have 6% initially, and then 80%. I mean, you could see that's a Seller 4. You see the apex here of the left ventricle. So we eliminate some of these configuration, and we kept A, B, and D. That's 19 patient, 19 animal, and there was some beautiful result, the good, as I said, but there was also some bad and ugly. And I'm finishing by why is like that. I think that in vitro performance, we realize that the so-called pinwheeling effect with redundancy of the valve and plication and excessive coaptation could be a problem. It's maybe the excessive coaptation which is responsible for the asymmetric tissue coverage more prominent in the aortic side than on the ventricular side. And I think that I have to go back with my friend to the shear stress of the leaflet. What we are currently doing is that we have this fast filming of the valve. We are digitizing the velocity of the motion of the valve. We are combining with STL file and get the finite element, combining both, and then we are able to see where is the stress computation, the von Mises stress in the valve, and that's maybe the possible site for a future tear. And indeed, in vitro, after 100 million, we saw that kind of tear in the material, but also in the animal almost at the same site, so it could have been predictable. And recently, we have shown the interaction of the causality between the leaflet tear and the diastolic inward deflection of the post supporting the valve. And there is also a quite nice correlation between the inward deflection and the calcification at 12 months. So, did the animal choice, sheep, and the selection of the metallic platform clipping and self-expanding interfere with the mechanical properties of the leaflet matrix and with the biorestorative process? A big question mark. I hope that Sir Magdi will help me to understand that. Maybe, after all, the bioreactive material was correct. This is my final slide. Maybe we have underestimated the complexity of the mechanobiologic situation. We have this end diastolic inward bending of the metallic scaffold. We have seen the conclusion, very simple relationship with calcification, wear, and tear. I think we have to go to more complex approach with the shear stress and the von Mises stress to understand. After all, if you follow by MRI a patient with the Ross operation 10 years later, after Ross operation, the valve has a beautiful velocity, which is not the case of homograph, bioprosthesis, and LT control. There too, Sir Magdi is right. So my last slide is to say that I've learned the hard way that history taught us that new technology needs time for maturation. If you see, the first stent was in Charles' daughter in 1966. I put the first wall stent in 1986, but it took 32 years to have the ESC saying that drug-eluting stent should be used for all. If you look at the bioresorbable scaffold, it took me also 30 years. And then yesterday we saw that Alain Cribier had needed 34 years to get to the low risk as a preferred strategy. So you need to be a patient. Will tissue-engineered valve dominate in 2031? Sir Magdi, I don't think so. However, I hope to lose the debate, because if I lose the debate, it will become the future. Thank you.
Very, very nice. Ourania.
If I can ask a question, both of you, and then maybe you have like a few minutes to rebuttal, but what do you think with the current market right now that we have like giant companies like Medtronic, Edward, etc., and millions of people undergoing bioprosthetic stented valves that we know that, you know, there is certain issues with durability. So how do you think that this like current market affect the pursuit for this perfect living tissue engineering valve?
Before answering your question, ma'am, I'm absolutely delighted that my colleague here admits defeat and joins me in saying it's only a matter of time. Well, I think we totally agree, and sorry, but you have lost yet again. Because
this is the future.
Because we agree entirely that this is the future. To come to your point, I'm not sure I understood the question. Is it stented versus unstented? Why are we using stented valves? The big companies are still producing stented valves. That was the subject of a debate here in Sitges between Alain Carpentier and myself. And at that time, we debated, should we use stented or versus unstented? And I was of the idea that stentless is, like you have shown beautifully, and we have some similar studies, that the biomechanics of a valve depends on geometry, dynamism, movement, and that cannot be produced completely with a stented valve. So I don't understand why we don't use stentless valves, and we know from the beautiful work of starting from Leonardo da Vinci, then the work in Oxford, showing that the vortices are essential, and now we have 4D MRI flow mapping, and we can quantify the size and the speed of the vortex to actually control coronary flow, but also stress on the valve, like you have shown. We have many tools which we can use now, and we should be using unstented valves. The freestyle is an attempt towards that, but it's not commonly used. I don't know why. Thank you for agreeing with me.
Last comment with
I think the question was also very specifically why the big company doesn't go in that direction, okay, because there is an history, etc. I think it's looking at my own career being sometimes between the industry and the inventor, and then you have the investor in between, which is very important. And you know, many of these big companies are led by venture capture people. And I'm afraid that when you got in the biology, you always underestimate the problem. That's what I have seen many, many times. You take the drug-eluting stent. Elizabeth Nabel told us you upregulate the P27 and the restenosis will go away. She was right. But how much time it takes to convince the industry to put that molecule on the stent? That's an example. And the myogenesis and the angiogenesis has been exactly the same story. 20 years ago, we went into the myogenesis in patient, ignoring 99% of the biology. And then you learn the hard way, and it takes time. Because you said yesterday that there is in one cell so many things. And that's basically what takes time.
Well, listen, this has been a tremendous look into where the future is going in this space. I think that there's some real nuggets that you both have brought to the audience, so thank you. And we're right on time, and we'll move on. So big round of applause for our debaters.
Thank you.
I would like actually to introduce Dr. Murat to come up into the podium to debate me with regards to the redo AVR versus valve-in-valve TAVR.
Good morning. Let me start by thanking the organizers to make me part of this really wonderfully enjoyable session. And then, but I'm afraid, as an audience, you're conned. This session was built as a battle of the giants, and you indeed got giants. I mean, look at the last two, Professor Serruys and Sir Magdi Yacoub. Something happened there, and how did you get me? I don't know. But anyhow, I also, again, did not fully understand, because what I was asked was, what does the science say in 2019? I did not see the clarity to create a debate. So I thought that maybe we can find a way with these two talks, somewhat not contradicting each other, but looking from two different windows, and maybe we can understand what the science says in 2009. So mine is not as entertaining my talk as Dr. Magdi Yacoub's and Professor Serruys'. In 2019, we know that bioprosthetic valves are used in greater than 80% of aortic valve replacement surgeries in the United States. Based on randomized clinical trials, we know that TAVR for native valves is very safe and effective. Valve-in-valve TAVR, on the other hand, is used in patients with failed surgical prosthesis who are at high risk for redo AVR, but there is no comparative data, real comparative data, certainly no randomized data. And valve-in-valve TAVR is approved in FDA based on single-arm registries. And if you look at the valve-in-valve issue, there is one very important study, I find, and that's the first large-scale registry communication about this technique. Danny DeVere should be credited for that. 2002 patients, 78 years old, about half and half in man and woman. They look carefully of the mode of failure, and then about two-thirds, close to two-thirds of the patients received a balloon expandable valve, large multi-center, multi-continent registry. Yeah, as any big registry had some shortcomings, but nevertheless, this was the first report of patients who were done in the 2 years between late 2010 and 2012. Look at that. Death at 30 days, 8.4%. Major stroke, 2%. Coronary obstruction, 3.5%. We know that is highly lethal complication. And another thing that Danny taught us, that if you have a small surgical valve, you get a high gradient, and then in those cases, perhaps a balloon expandable, a supraannular opening is a better choice than intraannular. But I think the small surgical valve, that's another important marker. So with this, we had some information, and took a lot of lessons. This on the right-hand side, this information was communicated very aggressively, and I think that the TAVR community should be congratulated to learn the lesson and to find solutions to these problems. Which valves are the valves that are most prone? What is this root anatomy that gives you the highest risk for coronary occlusion? How to avoid that? Even the risk is high, what are the techniques to go around and not get that lethal complication? And as a result, a few years later, a single-arm registries sponsored by the industry using sapien valves and the core valves demonstrated very clearly coronary obstruction much less than 1%. Despite high-risk patients, quite good results. 30-day mortality 2.7% and 2.2%. And then and 1-year mortality in 12 to 14% range. But if you notice, the post gradients are 17 millimeters, 17 millimeters, 16 millimeters, so they are not as low as native valve TAVR. Well, we published a paper last year from the TVT registry, a large United States registry of TAVR patients, because we knew that there was no head-to-head trial comparing valve and valve and then redo surgery. That's the ultimate trial we should have, don't we? Can we compare the safety and efficacy of valve and valve to standard TAVR? No, because I think you can't really do a comparative effectiveness study when pathology and procedure are inherently very different. You just can't compare the apples and oranges. But perhaps you can construct a hypothesis of whether valve and valve TAVR is comparable to a benchmark. That is, native valve TAVR, which is already proven in randomized clinical trials that it works, is safe and effective. That makes sense. That is how we went about. We queried the TVT registry between 2011 and 2016. As you know, that in that time frame, the TAVR wasn't approved for intermediate risk yet, so these are all high and extreme risk patients. And then there were about 3,000 valve and valve cases by then, and valve and valve wasn't approved. 44,000 were linked to CMS data over age 65, so that we had 1 year data. And then we did a 1 to 2 simple matching, taking into account patients' STS prom for reoperation, and we made sure that we used the STS score more for assessments of comorbidity. So we elevated the native valve to reoperation status. We matched the groups for inoperability and then hostile chest or porcelain aorta. So, and then we ended up with about 1,150 patients in valve and valve and 2,260 patients in native valve. And we looked at the 30-day outcomes as well as 1 year outcomes. And balloon expandable were 500 and 650 had the self-expanding valves. There were, despite our matching, there were differences, but if I summarize the differences for you in the two groups, there were more symptomatic in valve and valve, more atrial fibrillation, more pacemaker, more prior surgery, more prior CABG, more mitral valve disease, more tricuspid valve disease, lower EF, but the patients in the native valve were older, more women, less mobile, probably slightly more fragile maybe, and more diabetes. Procedural complications aligned much more with the single-arm partner and core valve registries than the old global registry. And when you look at that, the striking thing is there was no difference in complication rates between the valve and native valve. Coronary obstruction, device embolization, perforation, aortic dissection, annular rupture, conversion to surgery, cardiopulmonary bypass. Yeah, even there is slight favorable for bleeding and vascular complications. But when you look at the 30-day and 1 year outcome of mortality, there is no doubt that the valve-in-valve, at least I don't want to use the term superior to native valve, but at least is as good as the surgical valve, as the benchmark that we chose. Same thing for stroke, same thing for heart failure and hospitalization. No difference in aortic valve reintervention. And when we looked at this in different subgroups, I just put here the older and the younger, it didn't make any difference. Every subgroup, pre-specified subgroup, we found the same difference. I think that if you do a valve-in-valve TAVR, you get a very favorable response in comparison to the benchmark. When we look at the gradients, it's a slightly different story. We looked at on the left upper panel, you see the valve-in-valve versus native valve. It's very clear that you get a better hemodynamics in the native valves. Very understandable. Every other study has shown that. And when you look at the mode of stenosis, there's much more calcium, much more, I think, that reason for stenosis in stenotic cases. You get higher gradients in that group. But it's also important to note that the baseline, of course, is different. So when you look at these gradients in aggregate, you got to take into account that there's a group of patients that were intervened for aortic regurgitation. Those patients at baseline do not have a high gradient. And when you look at here, this is the very, very important point for practitioners. Look at the surgical valve size, 19 millimeter, 21 millimeter. You stay in the 20 millimeter range afterwards. And then same thing. If you have a small valve, you can't put a larger valve, and you end up with very large gradients, which is, I think, very important. I think there is a difference. We did not do a formal comparison like some others, but balloon expandable valves, particularly in small sizes, they really don't give you a good hemodynamics, unlike the supraannular valves. Now, what are the correlates of that one-year mortality? In the global registry, I intentionally put this in here. They found that the mode of failure is important for mortality. We did not find that. Others didn't find that either. I think part of the reason is that in this study, patients with stenosis, coming with stenosis, clearly had higher gradients afterwards. That was not always the case to the magnitude in other studies. But if you look at the partner trial, and if you look at the original study or the initial study, the smaller the valves, the chances of higher mortality is there. Even in the core valve, that they didn't find this, but I think that the numbers, particularly numbers in the smaller valves, are small. When we look at our own data, we see a difference. It is usually around 1.2 to 2% if you put valves 21 and higher, but we had about 62 cases that received a transcatheter heart valve in a 19 millimeter valve that was 1 year 30-day mortality was over 6% in those cases. So I think there is no doubt in my mind that when you leave a high gradient behind, 20 millimeter to 30 millimeter, that can't be good for long term for any patient. So what does the science say in 2019? Valve-in-valve TAVR, which was compared to the benchmark native valve TAVR, is safe and effective in high-risk patients with degenerated surgical prosthesis. Mortality, stroke, and procedural complications are low. Improvement in the hemodynamics is clear. However, transvalvular gradients are higher than native valve and SAVR cases, surgical valve cases, particularly in stenotic valves as small surgical prosthesis. I think this is something that we should take very seriously when we're started to think that, hey, maybe 50-year-old, we're going to put a prosthesis in, wire prosthesis in, and then we can put a TAVR. I think you got to make sure that you don't get high gradients. And long-term, beyond 1 year, data is limited. Hence, caution is warranted for, as I told you, about the prosthesis mismatch and durability and thrombogenicity. Just a few words about durability, not much data at all. This is the best I could find, 116 patients. This is from a Canadian group. You see here the characteristics of the patients, and the median follow-up of 3.2 years, range 2 to 7, mortality 26%. They looked at such structural valve degeneration, either subclinical or clinical. Clinical, they found only 3%. And if you look at these graphs, they had 61 patients that had paired echocardiograms, paired meaning that on 4 points, and it's fairly durable in the overall group. In the larger group, they have a curve like this, but if you take the 18 patients, 5 subclinical, 3 clinical, you see that there is this deterioration. But that number, that 3% clinically meaningful such structural valve deterioration, is no different at this time frame than the standard TAVR. So I think that there is not a big signal, but the orifice that we create and then the amount of tissue that we put in there, a valve within another valve, I am not sure that we still have the freedom to say that we can rely on this for long term yet. Thrombosis is an issue. 300 patients from a valve-in-valve international data registry, equally self-expanding and balloon expandable, 7 centers over a 10-year period. They found clinical valve thrombosis 7.1%, not necessarily clinically consequential. These are the thresholds, how they called it. And then what they found was, if patients are not on anticoagulation, if the surgical valve is porcine or mosaic or Hancock 2 prosthesis, it makes an incredible difference. Look at that. If patient did not get any of these stented porcine prosthesis and they were on anticoagulation, no thrombosis. On the other hand, it jumps up, and if the patient has either one of these high-risk prosthesis and not on anticoagulation, 1 in 5 get thrombosis. But the good news is none of them got into trouble clinically. When they were caught, they were put on oral anticoagulation and all resolved. Nobody required a surgical intervention. Let me leave you with this slide to answer the question. Patient selection is critical. Here you have a mitral flow valve. The coronary is very low. The sinuses are not large. The valve size is small. Well, you don't have any coronaries left after intervention. That is an immediate risk. Well, even if you get this patient through here, with that size valve, you probably will get a high gradient. So I think that the patient selection is critical for the success of valve-in-valve TAVR. I think the heart team is the way to go. So that next speaker, I think, is my partner from the heart team. Thank you.
Thank you, Murat. Ourania, tell us the surgical side.
Thank you again. I would like to thank Dr. Takenberg and Rakesh Suri for allowing me to participate in the meeting, and I'm really honored actually to be here. Definitely I'm not the giant, but I'm debating one of the giants, no question about it. So the topic is Redo AVR versus valve-in-valve, the science in 2018 or 2019. And somebody actually could ask, you're a heart surgeon, and what is your relationship with wire and catheters? And I have to say that was actually a landmark year for me. I was finishing my training, and in 2005, Michael Mack, during the STS ATS Tech conference, he had actually he invited 2 great speakers. One was Alain Cribier, and the other one was Ted Dietrich. And I talked to both of them, and I was contemplating to go and spend a year with Alain Cribier versus with Ted Dietrich. And being in the U.S. at the time, finishing my training, I thought it was a little more convenient to stay in the U.S., so I ended up spending a year at Arizona. And at the time, Dr. Dietrich was one of the few cardiac surgeons doing really a lot of not only open heart surgery, but also a lot of endovascular procedures. And you can see here these famous slides. Both of these slides are from him. That we can see only that offers percutaneous therapy for the entire aorta, starting from the aortic root all the way down to the aortic bifurcation, in a time when really very few things were known with regards to the percutaneous therapy. So I'm going to start this debate by this patient presentation, 76-year-old female, morbid obese, AVR 19 mosaic, 11 years prior. She was quite symptomatic, so we wanted to see what we're going to do, and of course we are part of the heart valve team. And we like also to see what the Google says, so we Google it, and in addition to our discussion. And we saw that there is this app, VAV in aortic and valve in mitral. So when we check the VAV in aortic for the 19 mosaic, there's nothing really, there's not a lot of options. Nevertheless, we did consider that this patient was high risk, and the entire heart valve team decided to proceed with a fracture, and this is what we did. Now, after we finished actually the TAVR and the biofracture, the patient, he improved a little bit, but continues to be symptomatic. And finally, we bite the bullet and we operated on the patient. And we can see here we took out the 19 mosaic that was fractured. And we took out the core valve that we have placed, a 23 core valve. And then we placed an Intuiti rapid deployment valve 23 on the patient. And of course, after every story that something fails, then there is a success. This is another patient, 63-year-old, had a prior ascending hemiarch and Medtronic freestyle 23. And we did consider it, even though the STS score was 3.2, given the fact of the prior surgery, the patient was deemed to be a high risk. So we proceed by doing a transapical approach. And because to avoid the kink of the Dacron graft, as well as due to the height of the coronaries, we put a sapien valve, and was 26. And that's another one of our cases, 21-year-old, 3 prior sternotomies. Patient had a homograft that failed, and he had severe AS as well as AI, mixed lesion. And we placed transapical a 26 Edwards Centra valve. So everybody has his stories, and there is always a success and the failure, but the question is what are the data that we have? This is what we know. That was just recently presented on the STS in 2019. That after following the approval of the valve-in-valve in 2015, the number of patients that undergo reduced surgery for bioprosthetic AVR is declining, and the patients who received reduced surgical AVR are actually younger, tend to be younger patients and low risk. And we do know that there is this trend to implant more bioprosthetic valves in younger and younger patients. And if we do see the guidelines, we heard from the other speakers that, the deterioration, the structural deterioration is really very severe in young patients. And we can see this quote from Blasé Carabello that say that the prospective strategy of placing in a young patient to implant a bioprosthetic valve with the hope to perform it a VAV TAVR, if this first valve fails, actually most likely will not work in younger patients, because we do know that the deterioration is actually quite severe, especially at the age of less than 60. So there's definitely quite of disadvantages. Let's see the reduced scenario for the AVRs. This is 7 European institutions, 711 cases. They included everybody: endocarditis, emergency, nuclear heart classification, 4 older patients. And they found that the overall mortality was 5.1, and the isolated hospital mortality for the redo AVR was 4.6. With an overall stroke of 6.6, including permanent as well as temporary, but the overall mortality was 4.6. So I would like from you to remember actually this number as we're going to go through this debate. And at the same time, the freedom from reintervention, thromboembolism, as well as from stroke was quite good. And the authors concluded that these emerging strategies might be considered for high-risk cases. And let's see this partner 2 VAV registry that Murat actually alluded to. Definitely the mortality was 2.7, but as we see here, they started with 8.3 and then it went down to 0.7, so definitely was a learning curve there. And then, of course, we see the study, and on the study they excluded patients with bioprosthetic valve less than 21, excluded patients with a mild perivalvular leak, excluded patients with an EF of 20%, and they included, of course, everybody suitable with either 23 or 26 sapien valve. And as a result, the functional and the quality of life was excellent at 1 year. But when we see a much closer the study, in 58 patients in the first post-op echo was severe PPM. And also the surgical valves with a true internal diameter of less than 20, and we have to know that most of the 21 valves currently stented, they have less than 20 ID, were strongly associated with post-TAVR gradient. And of course, with the post-TAVR gradient, the mortality on the study found to be increased at 1 year, with a trend to be increased mortality in patients with PPM. So what we know about this study, carefully selected sites, extensive oversight. We look only like 2 sites, 23 and 26, was not inclusion of patients with smallest or largest valves, and they look only 1 valve, the sapien. And here, of course, I quoted from Murat's excellent paper that say that in the smaller valves that actually the study didn't really include, you have the post-TAVR gradient was higher, and we know from the study that the patients with the post-TAVR gradient higher, the mortality was also higher. Of course, we'll see this data from the global registry. Overall mortality 8.4%. You remember that the previous study that I showed you from the European for the reduced surgical AVR, the mortality was 4.6. And on the upgrade data for the 2014 with more patients, mortality remained at the range of 7 or 8%. And the patients with the smaller valves, they had poorer 1-year survival. Of course, when we see the comparative studies, and there are actually a few of them, and all of them came in 2018, you can see here, I would like for you to see this one, 4 observational studies, 489 patients. This came close to April 2018. Similar events between TAVR and redo AVR. Now, 5 studies, the previous was like 4 studies, 5 studies with less patients, so how critical we have to be when actually we see the different reports. Just this came in March 2018 that showed that there's no difference in mortality, but was some on the survival analysis that was favored the surgery. And the VAV had shorter ICU, shorter hospital stay, but the redo AVR had superior echocardiographic outcomes, lower incidence of PPM, lower TAVR gradient, and fewer perivalvular leaks. So the author said that is actually the VAV-TAVI is good for inoperable or high-risk patients, versus the redo AVR is actually should remain the gold standard for the low-risk population. And then this is actually a few months later, 6 studies, 594 patients. VAV had less permanent pacemaker. We had the same mortality, stroke, and the gradient, but there is increased risk for perivalvular leak, and this is really one of the Achilles heel for the valve in valve. So the authors again said that there is a safety and feasibility valve in valve, but in patients deemed to be high risk for surgery. And this is another study, 30-day mortality we'll see, and the author said that both actually techniques are complementary. What is the downside? We can see the valve in valve, there is these wrinkles that actually develop, and because maybe the stent of the prior bioprosthesis prevents this full opening of the valve. As a result, we have the creation of thrombus. And you can see this is a very nice paper when actually said what is exactly should be the deployment and how the deployment should be done of the sapien valve versus a core valve in a prior perimount valve with a size 23. And also they found that actually the best location for deployment for the sapien valve is supraannular, 6 millimeters, versus the core valve, when the best deployment is actually at the normal position. And we see here that how the core valve, the 26 core valve in a 21 bioprosthesis, if placed in the supraannular position, you can see this constriction here versus when it's placed in the normal position. So what do we know? That the device success is likely to be affected by the characteristics of a stenotic calcified bioprosthesis. We still have a lot of things to learn, and we're still learning with regards to the best deployment position for the different valves. We do know that we need hemodynamic performance guidelines and not just VAV application guidelines that just look geometric observance. And then, of course, we do know that valve-in-valve, one of the Achilles heel is perivalvular leak, and this is really a concern because of the suboptimal expansion. So what happened with the patients with the prior small bioprosthesis, how we deal with the problem, and we know here from Keith Allen regarding the biofracture, we have the 3 valves, current, Hancock, Avalus, and trifecta that we cannot fracture. And as surgeons, actually, another way to deal with the problem is that by maybe trying in the future to implant newer valves, which actually could potentially fracture. And also, or in the first operation to avoid a small bioprosthesis and surgically enlarge the root. So as a conclusion, in 2018 and 19, valve-in-valve is safe and feasible. But it's still something that we can actually have for inoperable or high-risk patients. We do know that the reduced surgical AVR is safe, and this should be the standard of care for the low-risk patients. We still don't know what actually the science will say for the intermediate risk category. There's no question that in 10 years from now, most likely valve-in-valve will be the way to go. But definitely one thing that we have to make sure is that great hemodynamic result is extremely important for the patient because this is whom we serve every day. Again, thank you for this great opportunity.
Thank you very much, Ourania, and thank you again, Murat. The very comprehensive discussions by you both, and I believe that both of your perspectives overlap significantly. We're out of time, but I would ask for a last comment from each of you in terms of what you'd like the audience to take away.
I think valve-in-valve TAVR is very safe. I would submit that safer than from what we know from surgical AVR, both from the standpoint of operative mortality, stroke risk, and permanent pacemaker risk. So I think that unless that there is high risk of patient prosthesis mismatch or high gradients or particularly high thrombosis risk, I would probably venture that most patients will be suitable for a valve-in-valve. They can always have a second surgery.
Yes, I kind of agree, but I disagree. Because still I do think that for the low-risk patients, redo AVR, at least in 2018 or 19, is the way to go. Again, for the low-risk young patients, there's no question that for the high-risk, valve-in-valve is the way to go. And most likely a few years from now, as we're learning more and more and the technology is improving, and we learn actually how to deploy and how exactly to deploy these different valves. I think eventually will be valve-in-valve will be the way to go into the intermediate risk category.
Okay, that's it. Thank you so much. Appreciate it once again. And I'd like to invite the next two speakers up, Dr. Marta Sitges and Joanna Chikwe. The title of this debate is Imaging Does Not Influence the Timing of Degenerative Mitral Valve Repair. This will be a very interesting one again. And let's start with Marta.
Thank you very much. Okay, so I also feel like Dr. Suri is like a little mouse more than a giant. So we are going to the debate the affirmation of imaging does not influence timing of intervention in degenerative mitral valve disease between a cardiologist and a cardiac surgeon. So I will defend the position that imaging does influence timing of degenerative mitral valve repair, and this is my first conflict of interest. I am a cardiac imager, so definitely I am absolutely convinced that imaging is essential to decide when you have to intervene a patient. The first thing is that for sending somebody to intervention, MR should be severe. And I think we would all agree that probably we will be more likely to send this patient for intervention with a more severe mitral regurgitation, more enlarged left atrial, and probably more hemodynamic impact, despite both might be asymptomatic. But also, imaging can quantify the amount of severity or the amount of regurgitation, and this has been, as you well know, correlated with the prognosis. You may say, oh, echo is not useful. Who does PISA? Who cares about PISA or any other methods that we use to quantify? Okay, there are upcoming methods that also confirm this ability of the correlation by quantification of mitral regurgitation and outcomes. So definitely imaging has something to do on classifying the amount or defining the amount of mitral regurgitation. So that's our first step. Also, if we go to guidelines, wherever, European, American, in patients, of course, who have symptoms, we have to, and these symptoms are explained by the presence of severe mitral regurgitation. This patient should be sent to intervention. But when we go to the asymptomatic patient, which is probably the patients that we are debating, again, there are some parameters that guide us and are based, again, on imaging, which is ejection fraction and systolic diameter, and even the presence of pulmonary hypertension. So again, the hemodynamic impact is based in imaging. So second thing, based on imaging. And we know that if we follow these guidelines, and this is has been controversial, these are the latest data published by the group of Austria, defending the position of watchful waiting and following these guidelines. Okay, we know that with follow-up, some of these patients, 161 out of 280 patients, will go for surgery during follow-up because they will develop hemodynamic signs of left ventricular involvement that make us to decide to send them to surgery. But these are not so many patients, and we can effectively detect them if we follow them accurately. And this approach, indeed, when we follow this approach, which is this line in solid orange here, is not so different in outcomes as what would be expected in the reference population in the green line. So this has also proven to be safe, provided we follow these patients adequately. Dr. Chikwe may say, okay, this is useless. We know ejection fraction is not that good, and I agree. We all have patients like this one. This is a patient with degenerative mitral regurgitation, severe. She had symptoms. We sent her to surgery despite the left ventricle was not so bad. We can agree that the ejection fraction here looks normal, and this is the outcome after a perfect mitral valve repair. We all agree that we all have patients like this one. And indeed, this is a work from my colleague, Dr. Quintana and Rakesh Suri, the Mayo Clinic, showing that there are a quite important proportion of these patients with apparently normal left ventricular function defined by diameters and defined by ejection fraction, and thereafter even the surgery is perfect, they develop left ventricular reduction, they show reduction in postoperative ejection fraction. But we know, echocardiographers know, that ejection fraction is indeed a measure of desperation. And indeed, we should not be relying on it, because we know that when there is progressive left ventricular dysfunction, the first thing that goes down because of the disposition of the myocardial fibers is longitudinal deformation of the left ventricle. So the first impairment is on the endocardial fibers and the longitudinal deformation of the left ventricle. But this is what ejection fraction is not measuring. What happens with this? That the circumferential fibers try to compensate this decreased longitudinal deformation. So ejection fraction, which is measuring the radial motion of the left ventricle, is still preserved. So normal ejection fraction is not equal to normal left ventricular function. So we should go for a more comprehensive approach in assessing left ventricular function. And this has been really shown in the last decade. This is more recent data showing the value of other evaluations of left ventricular function using myocardial deformation, myocardial strain, and now we have currently technology that makes us very easily to measure global longitudinal strain, which has shown in several studies to add prognostic value and to clearly differentiate patients who are going to have a good versus a bad prognosis if we don't intervene on them. This is also work showing how this adds value on top of other indications, such as the presence of left atrial dilatation and atrial fibrillation, and while there is indeed no difference between adding ejection fraction. So let's keep on real indicators of ventricular function and forget a little bit of ejection fraction. Also, if we combine these parameters of myocardial deformation with the size of the ventricle, because the myocardial deformation will also depend on the size of the ventricle, and also we add the behavior of the ventricle during exercise, and that's something that we can do really easily in the echo lab during exercise echo. This has been shown to have a much more powerful prediction of outcomes in these patients. So we are really able to do a comprehensive approach of ventricular function much farther beyond of left ventricular function, of left ventricular ejection fraction. Finally, upcoming imaging modalities are even showing more promising concepts on the evaluation of myocardial function in mitral regurgitation, and this is the case for assessing interstitial fibrosis with T1 sequences in cardiac MR, and this is a still work in progress, but I'm sure that in the future this will help us in assessing precisely which are the patients that should, in asymptomatic patients, that should go intervention as early as they have been diagnosed. Indeed, this is foreseen in the guidelines. So this is a class 2A indication, as you know now. Patients who are amenable to have amenable to be repaired, who have a potential to have a repairable valve. Yes, that's something that we can also accept, provided that we can ensure a durable, feasible, and durable repair with a very low mortality, less than 1%, and that should be done in a center of excellence. Okay, that's good if you're lucky and you have this center of excellence. Again, imaging plays a role, an essential role, because this is the way we have to predict repairability of a valve. First of all, using a systematic approach with systematic views and the use of 3D, we can really define if a valve is amenable to be repaired in experienced hands, and this is how we really define if a valve is amenable to be repaired or not. defining if there is enough and flexible tissues, defining the mechanism of the regurgitation, and of course, we need an experienced team. But as I have said, this is sometimes far away from our reality. These are data from the UK. You may know this study, and this is the repair rate of the mitral valve in degenerative disease according to the hospital volume of cardiac surgeries. And as you can see, there's a wide variability. But even as recognized in this paper from Dr. Chikwe, from the group of Dr. Chikwe, you can see that the repair rate, again, varies among surgeons, not only among centers, but also among surgeons, depending on the volume they have. So this is, as they recognize, a complete lottery, depending on your referral surgeon that you have. And they also recognize that in these asymptomatic patients, if you don't repair them and you have to replace them, this is really a bad thing because you present much more problems than if you get repaired. So I hope that I have convinced you that imaging is the basis for deciding intervention in patients with degenerative MR. First of all, because it's the technique of choice in 2019 to quantify the severity of MR. Secondly, because we can assess the functional anatomy of the valve, so that's the first step to predict repairability. And of course, we are able currently, using a comprehensive approach, to non-invasively assess left ventricular function, combining all the parameters that we have currently in our imaging tools. So thank you very much for your attention.
Very nice. Joanna?
Well, while we're waiting for the slides, it's an absolute honor to be in Spain. It's a wonderful meeting. I love talking about mitral valves, but this debate is about as much fun as Brexit for a Brit. I don't know how I got an undefendable topic, and I don't know how I got to debate it against an imager of the caliber of Dr. Sitges here. So what I'm going to do instead is slightly modify it. I'm going to say that imaging should not dictate the timing of degenerative mitral valve repair. You all know the data that underpins the guidelines, so starting with Maurice's group that showed us how the survival of patients with degenerative mitral regurgitation and ERO greater than 40 was substantially worse than that of lesser EROs. And again, the cutoff of an LV end systolic diameter of greater than 40, which predicted both worse survival in treated and inoperated patients after surgery. And similarly, left ventricular ejection fraction, such that if you have patients that have any of those class 1 indications for surgery, the watchful waiting is associated with superior prognosis, as Rakesh demonstrated in this multi-registry analysis of about 1,000 patients, half of whom waited for surgery for about 3 months. And this is essentially what underpins our guidelines. We're all very familiar with the class 1 American and European guidelines for surgery in asymptomatic patients. And I think it's worth just pausing and thinking about these. So if you're sitting in the office with an asymptomatic patient with severe MR in front of you, you have a mandate to operate if their EF is decreased or if their ventricle is slightly dilated. And that's quite a responsibility because essentially you're deciding to operate on a patient purely on the basis of an image. And the rationale for that is worth looking at a little bit more closely. In asymptomatic patients that have no ventricular dysfunction, we're still deciding whether to operate purely on the basis of an image. In this case, it's whether based on the imaging morphology, we think a successful and durable repair can be carried out safely and reliably. So in order to deliver our evidence-based guideline adherence, we need to know a few things. We really need to be sure that we can determine the mitral regurgitation grade. We need to know the mechanism of regurgitation. We want to understand the etiology of MR. We obviously need to know the ejection fraction and the left ventricular dimensions. How accurately can we do that? There's not a lot of data in the literature. There's one paper, again from the Mayo Clinic, and this group looked at 377 consecutive patients that happened to have echoes both at an outside lab and at the Mayo lab. It's a range of outside labs, some accredited, some not. And these researchers were able to review all of the echo images independently and compare the interpretation of the results. And this is a recent study. This is not sort of decades-old practice. This is contemporary clinical practice in North America. And their findings are astonishing. The authors write in their results that quantification of mitral regurgitation in their own lab and in the outside labs was of suboptimal quality and non-diagnostic in a third of studies. A third of studies. The bar chart on the left shows that in patients that were referred to the echo lab with reports saying that they had less than moderate mitral regurgitation, 40% were read incorrectly when they were reevaluated by the Mayo echocardiographers. And conversely, in those patients referred with more than moderate regurgitation, there was discrepant finding in about a fifth of patients. The authors write in their results that the planned operation was cancelled. This is the Mayo Clinic, because the valve lesion was felt to be less than severe. That was in 80% of patients with discordant grading. In 15% of patients with discordant grading, the valve lesion was graded severe by the echocardiogram performed at our institution, which led to an operation that would not have been indicated based on the external interpretation of the study. Now, that's just discordant grading of mitral regurgitation. Let's just look at what was even reported in these echoes. So, left ventricular end systolic dimension, not reported in about 10% of cases. LV size not even commented on in 7% of cases. Mitral valve morphology variably reported, up to 95% it was present. But the things that determine as surgeons whether we feel confident about operating and repairing these valves in degenerative patients and our ability to identify degenerative patients was not reported in 2/3 of patients. Half of patients in the Mayo Clinic's own lab. So for guideline-based practice, we did accurate assessment of MR grade. That was discordance led to inappropriate surgery in about 15% of patients. The mechanism of MR was not reported in 2/3 of patients. And left ventricular dimensions were missing in 10% of patients. So without profound practice improvement, relying on a single echocardiogram to guide the timing of intervention in MR, it certainly in contemporary US practice seems questionable. The other element of these guidelines is obviously this need to be able to sort of state with confidence that you'll be able to safely repair and durably repair a valve with a certainty of 95%. And that is pinned on this concept of reference centres that basically dominate our literature on what's going on in the real out there. And these reference centres report stunning results with operative mortality less than 1%, low stroke rates, very high repair rates with very low residual MR, very low recurrent MR, and low rates of reoperation. What's happening in the real world? Well, I think as Dr. Sitges alluded to, there's huge variation. So this is the Society of Thoracic Surgeons database analysis done by Jim Gammy. It's quite an old paper, but the results are still pertinent, and they were very similar in his recently updated paper, although he didn't look at this, which is why I'm using this slide, in his more recent paper. And the slide is relevant because it shows the huge variation in mortality between centres, with the lower volume centres having up to 3 times the risk-adjusted operative mortality of the highest volume centres. Similar outcomes for stroke. So already you're seeing that there's a huge variation in operative mortality in stroke, let alone repair rate. So again, Dr. Sitges showed this slide from the UK database, and this is very similar across Europe. The prevalence of replacement in patients presenting with mitral valve regurgitation is far higher than ideal. Each red dot in this histogram represents an individual surgeon in New York State. There's obviously a far outlier with a high volume and 100%, well, let's call it a 99% repair rate. But there are a number of high volume surgeons in degenerative disease that are repairing only about 60 or 70% of valves. And the other factor, the durability of their valve repairs, is also very correlated with the volume. So the line in blue represents surgeons that see the mitral valve twice a month or more. And the line in red represents, less, and the line in red represents surgeons that see the valve twice a month or more often. And this is the failure of repair within 12 months of surgery, much, much higher for the lower volume surgeons. So reoperation rates are higher than you would want to operate in asymptomatic degenerative patients, and the repair rates are much, much lower. And finally, recurrence rates, again, higher in most hands. So I think this push towards early intervention based on single echocardiograms in asymptomatic patients is obviously very swayed by your ability to manage the factors that contribute to the balance of risks in patients. So this vertical line here represents the net health benefit of null to a patient undergoing surgery. And the factors that shift you towards the right, i.e. a benefit, are a very low repair mortality, a higher incidence of congestive heart failure if you're observing the patient, a high probability of repair with a very low stroke risk, and very low replacement mortality. You're all familiar with this concept that to improve these results, we should focus on reference centres, sending these simple, straightforward repairs, the isolated posterior leaflet prolapse, single segment, to surgeons in the community, and referring bileaflet complex prolapse to reference centres. I think it's a fallacy. I think it's a fallacy for several reasons. The first one is centred around that series of slides at the beginning that show how difficult it is for echocardiographers, certainly in the US, to provide us with reliable, valid, accurate assessment of mitral valve disease, etiology, severity, let alone mechanisms. And secondly, this chunk of missing data that doesn't allow you to accurately identify the patients that are appropriate for surgery. Tyrone David put it very well in his editorial in JTCVS. He notes that even in socialized medicine, such as operates in England and Canada, this centralization of specialist healthcare services is difficult to achieve because essentially cardiac surgeons believe that they're all entitled to manage and they're all incentivized to manage patients with mitral valve regurgitation. So, in conclusion, I don't believe that imaging should dictate the timing of surgery in the real world because of this huge variability in the completeness and accuracy of the echocardiograms we rely on to make our decisions, and because of the wild variability in the quality and safety and durability of surgical repair. Slavage adherence to image-based guidelines likely to result in excess, inappropriate, and potentially harmful intervention. Thank you very much.
Thank you, Joanna. So let's have a comment from Marta on what we just heard.
Well, indeed, I am quite happy because I definitely agree that a single echocardiogram does not make it, but probably good echocardiograms and confirmed echocardiograms do make it, according to your presentation. So in the end, I think we could come up to a treat and being in accordance, but also if we look at the real world, these centers of excellence are not available everywhere. So we should pursue on improving technical surgical techniques, but of course also imaging. So I think that this is quite the way to go.
Is Maurice in the room? Maurice Serrano? Maurice, yes. Come. So the great thing while Maurice is coming to the mic, so Joanna and I have been on the stage together about 15 years or so, and the great thing is she always likes to pick on the Mayo data, but now they've left Mayo, I can't defend it. so Maurice, you're on.
No, there is nothing to defend. Yes, surgeons have to improve. Not all surgeons are equal. Not all doctors are equal. Not all imaging is equal. You have to have the concept of screening echo. A guy is doing echo in the community, and he's saying, I see MR, I am alarmed, I'm going to refer to people who know what they're doing. And in the journals, you find a lot of people reporting echoes, and they don't know what they're doing. So as you said for surgery, for echo, it's the same. You have to know what you're doing. So screening echo, then referral to a heart team, and then you do the right thing, and you get good results.
Beautifully said. Joanna?
I think where it falls down is on the referral to the heart team. Certainly in North American practice, there are very few surgeons that are not incentivized to keep every single patient close to home. And until you address that, then you're going to be stuck with this problem.
And that's the responsibility. That is the responsibility of the cardiologist, to act with discernment, to say, okay, I have this patient, I'm going to act for the benefit of this patient, to choose the person I'm going to refer to choose the center I'm going to refer to. The surgeons, they're all waiting, and everybody, as a surgeon, can you say I cannot do A or B or C? No, they won't tell you. So we know that, and the cardiologists have to say, okay, I know where to refer my patient. And we do the same with interventional cardiology. You don't refer to interventional cardiology, you refer to a person who's going to do it right. And so that's the purpose. So us as cardiology, discernment on what we do with echo, discernment on where we refer the patient.
The other point, though, is that you don't necessarily want to make echo the hinge point of that discernment. I think refocusing this view on what reference centers should be handling away from echo determinants towards clinical. So you look at the high stakes patients, those are the asymptomatic young patients with probably normal ventricles, and the high risk patients, they're the complex, third time re-op, awful ventricles. That may be more reproducible than running by echo.
This is getting interesting now, just as we're about to close the session. Okay, Maurice, go.
Just again, the echo is we have to make the judgment and not focus on one thing in the echo, and again on making the assessment and sending this patient to the right place. The clinical judgment, I see a ton of patients, you have the same thing. How you doing? I'm okay. And what do you have? 3/6 murmur. You can't determine anything. In valve disease, everything begins with imaging, because the clinical is established as being very weak, and very few high clinicians can do the right thing. And the mass of people are not the 50-year-old. Mean age of MR, 73. Treatment in Olmsted County, 85% of patients with MR are never treated for their disease. So our job is to detect these patients and to bring down the under-treatment of MR with every mean we have. That's the job, not to make it perfect for one 50-year-old. We have to make it perfect, but that's not the current mission. The current mission is to address the under-treatment of mitral regurgitation, which is massive.
Point taken. Murat, Tuzcu from Cleveland Clinic.
I just, for the first statement of Maurice, the responsibility is the cardiologist to get these patients to the right surgeon. I just wanted to voice my disagreement with that. The cardiologists, and together with the surgeons, I think showed the way in the last decade how TAVR should be done. TAVR is done in about 500 centers out of 1,500 centers that do interventions, and very strictly regulated based on the quality data that comes out. I don't understand, after 2 decades I've been listening to this, why the surgeons don't get together and then change this so that we really have some incentive to send this or obligation to send these patients to people who can repair. So I think that I want to send this back to Maurice, that it's not only cardiology.
Oh, perfect. Ourania, do you want to close this?
Yes, I would like to ask you, John, with the current training paradigm in the U.S., what do you think is the role of the surgeons for interpretation for echocardiograph?
I actually just focus on the current training paradigm for teaching surgeons how to operate on the mitral valve. The ABTS only just introduced a minimum requirement for mitral valve surgery, and it doesn't actually stipulate that a trainee should graduate having performed one single repair. So maybe we should start there.
Excellent. Marta?
Just a very quick comment, because I mean, absolutely agree with Maurice for sure, but we have to keep in mind that in most of the world we cannot select the surgeon that we are referring. So there's a lot to work on also on public health policies to establish this kind of networks. Maybe in the States you can choose the surgeon, but it's not that everywhere. So I think there's a lot of work and exciting work to do.
Excellent. Well, thank you all to the audience, to the presenters, to the debaters, and wishing you a great rest of the day. Take care.
Thank you.
Sorry?
Thank you. Very, very good.